Assalamu alaikum viewers. Welcome to VTeach24.
Myself, Dr. GhulamUllah Lail, Assistant Professor, Medicine and Allied. Angiography is most likely to detect the bleeding site. This is another diagnostic modality. Now we are in the diagnostic modality number 3. So, angiography is another diagnostic modality that can be used to detect the bleeding when its rate of the arterial bleeding is at least 0.5 ml per minute. You can see the difference between the two, the radionuclide imaging and the angiography. Radionuclide imaging can pick even smaller amount, 0.04 ml, and here at least 0.5 ml per minute should be there. An advantage of angiography is that the embolization can be performed to control the bleeding lesions. And in the radionuclide imaging, therapeutic intervention was not feasible. Like we have the therapeutic modalities feasible in the flex sigmoidoscopy or the colonoscopy. Angiography is also having the some techniques in which we can use as an therapeutic techniques, but there are the chances of the major complications, which includes the ischemia of the bowel, the hematoma formation, femoral artery thrombosis, dye reaction, kidney injury, or the transient ischemic attacks. So the disadvantages of other disadvantages of the angiography, which includes the absence of the patient is not actively bleeding at the time of the scan. We have performed the angiography. The patient is not actively bleeding, will not be detected. Inability to detect the non-bleeding stigmatas like the non-bleeding visible vessel, clot, or the flat spot at the expense of the test. We have performed the test. We have taken the chances of those major complications. Despite of those taking the chance of major complication, we are not able to pick this non-bleeding stigmatas of the hemorrhage. What are the non-bleeding stigmatas of the hemorrhage? Like the non-bleeding visible vessel or the clot. Even the flat spot can also be stigmata of the recent hemorrhage. So, inability to detect the specific lesion, especially which is responsible for the bleeding in the many of the cases. Angiography can only lead us the clue that the patient is bleeding, and usually is not going to give us any detailed information about what is the cause of the bleeding. Multi-detector CT scan, another modality. So you can think different modalities, either the diagnostic or that modality is having the option of diagnostic as well as therapeutic. So angiography has the diagnostic as well as therapeutic effect. CT scan, that too is only diagnostic. Multi-detector CT can identify the abnormalities in the colon that could be a source of bleeding, such as diverticulosis, colitis, masses, or varices. Masses, those the lesion of the CA colon, etc. CA colon, familial adenomatous polyposis, colonic polyp, polyps, sessile pedunculated polyp, masses, that is the tumor. So these all can be detected by the multi-detector CT scan. CT scan has shown to be more accurate than the technetium tagged RBC scanning in the patient with the lower GI bleeding. And we can also perform the CT colonography to detect the larger polyps of more than 1 centimeter or the cancers with a sensitivity of around 90%. So what needs to be done if we are planning for a colonoscopy or the flex sigmoidoscopy? Urgent colonoscopy following a rapid bowel purge has been shown to be safe, provide the important diagnostic information, and allow the therapeutic intervention. So if urgent scopic procedure, that is colonoscopy or sigmoidoscopy is needed, we used to perform the rapid purge. How to cause a rapid purge? Patient usually ingests 6 to 8 liters of polyethylene glycol, that is under the market name of Movcol solution. So via orally or NG tube over 4 to 6 hours until the rectal effluent is clear of the stool, blood and clots. Why we want the rectal effluent to be clear of the stool, blood and clots? Because we used the examination with a colonoscope that carries a smaller, carries a small camera. There will be the abundance of the stool, blood or clots within the colon. That camera, the VN will be blocked. If our VN is blocked, how we can detect the cause of the lesion or cause of the bleeding? And that how urgent it can be performed? From 6 to 36 hours. That is all urgent colonoscopy. Most of the bleeding stops spontaneously. Colonoscopy is often performed semi-electively on the day after the initial hospitalization to allow the patient to receive blood transfusion, bowel preparation on the first day of the hospitalization. Why I take at least 6 hours duration? Because as we have seen earlier, the colonic purge is needed, and for the colonic purge 6 to 8 hours, the patient takes around 6 to 8 liters of polyethylene glycol and the rectal effluent needs to be clear. So 6 to 36 hours time depends upon the amount of the blood within the gut, amount of the stool and the clots within the gut needs to be cleared. There is no difference between an urgent or elective. Urgent means up to 36 hours or even the less than 12 hours of the admission. Colonoscopy in the terms of the further bleeding, blood transfusion, hospital days or the hospital charges are almost similar, but it's better to have to receive a better outcomes at least 36 hours. So why urgent colonoscopy is not very urgent, less than 12 hours. Barium enema, though it's a diagnostic, but it's rarely diagnostic for the lower GI bleeding, can demonstrate some of the vascular lesions and can be misleading if the only diverticulars are seen. So surgery, the surgical management is rarely needed in the patients with the lower GI bleeding, because most of the patients bleeding is self-limited or early managed with medical or the endoscopic therapy. What are different endoscopic therapeutic interventions that are available with us for particular patient? We have already seen in a previous slide. So main indications of surgery are malignancy, diffuse bleeding that fails to cease after the medical therapy or the endoscopic intervention. Here you see different different therapeutic hemostasis options that are available with colonoscopy. Injection therapy, that includes the adrenaline injection or the vasoconstrictor injection. Hemoclip, that is mechanical device to stop the bleeding. Band ligation for the internal hemorrhoids, or the monopolar electrocautery, either with the contact or the non-contact. Contact is hot biopsy forceps and the snare polypectomy, and organ plasma coagulation is non-contact monopolar electrocautery. So these are the different therapeutic interventions that we may perform with the colonoscopy. We will not be going directly towards the surgery. Now we will discuss the different possible causes of the lower GI bleed and some of the essential points of those that can be kept in the mind. So diverticulosis, this is most common cause of the lower GI bleed. Most of the colonic diverticular are asymptomatic and remain uncomplicated. Bleeding may occur at from a vessel at the neck or the base of the diverticulum. Diverticular bleeding develops in an estimated 3 to 5% of patients with the diverticulosis. Most of the diverticula are in the left colon. Several series suggest that diverticula in the right colon are more likely to bleed. So here this sentence carries double meaning. You may not be taking this one. See, most common site for the diverticula is the left colon, but those the right colon are more likely to bleed. Almost about 1/3 of the patients with the true diverticular hemorrhage, urgent or the presumptive or the definitive groups, then during an urgent or following an adequate cleansing, have stigmata of the recent bleeding such as the active bleeding, visible vessel or clot, or the flat spot is seen in a single diverticula. So usually, even if the patient is having the diverticulosis, means the multiple diverticula, the 1/3 of the patient will have the active bleeding or the diverticular hemorrhage site to be identified in a single diverticulum. Stratifying the risk of the diverticular rebleeding by applying the same endoscopic stigmata, that is active bleeding, non-bleeding visible vessel or the clot, has been advocated. See here, that is diverticula with the active bleeding, and here it is a diverticula with a visible non-bleeding visible vessel. This is the vessel, and this active bleeding you can see. Diverticula, what diverticula is, basically it's an outpouching. Here it's a side view of the diverticula, and here it is central view of the diverticula. And while performing the colonoscopy, the hemostasis, we use the epinephrine injection, hemoclave, fibrin glue, or the combination of epinephrine with the monopolar electrocautery. Monopolar electrocautery is argon plasma coagulation, or the touch techniques in which the hot polypectomy scenario may be used. If fresh blood is seen in the focal segment of the colon, this segment should be irrigated vigorously with water to remove the blood and identify the underlying bleeding site. Non-bleeding visible clot, even if clot is there, we are going to perform the adrenaline injection. Then we need to have aliquots of 0.5 to 1 ml per quadrant. So at least 4 injections, 4 quadrants needs to be used to stop that bleeding. Here, 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 and here. So 4 quadrant, 1 ml each diverticular bleed may be stopped with the epinephrine injection. And then underlying stigmata is treated with MPEG or the hemoclave. Like this, the non-bleeding visible vessel will deploy hemoclave, and if there is ulcer or active bleeding is been, no visible vessel is seen that can be clipped, then we can apply the monopolar electrocautery. Embolization and or the surgery. Angiographic embolization, as we have discussed earlier, what may be the different causes and how we can use that. So angiographic embolization can be performed in a selected cases of the diverticular bleeding, but with the risk of the bowel infarction, contrast dye reaction, and the acute kidney injury. Surgical resection for a diverticular bleeding is rarely needed and is reserved for the recurrent bleeding. multiple bleedings are happening, then we can think of that. You may be worried about it's too much. Yes, it seems to be too much, but it will be beneficial for you for a lot of the perspectives. I hope you have understood.